So first, I just wanted to put in the slide for the center's purpose, and here you can see the 5 core areas that the center focuses on. I won't read those to you. You can learn more about that at ruralcenter.org if you're interested. And we want to include our, our diversity, equity, inclusion, and anti-racism slide, because that is the center of everything we do here at the center. It's very important to us in our work. And if you want to read more about that, you can also do so on our website at the link below. And our objectives today are to explain what NEMSIS is and what data is available, and discover how FLEX programs can access and use NEMSIS data, and recognize the process the data goes through from entry to availability on the NEMSIS website, and to understand how NEMSCORE works with NEMSIS. And we will spell out all of these acronyms for you during the presentation with Jeremy and Dr. Mann, so stay tuned for that. But first, we'll just go through some updates. So we'll do a task update, and then we have partner updates, and then we will turn it over to our presenters. So I'm going to skip ahead a little bit so Craig can go ahead, because he's got some other commitments this afternoon. So Craig, if you want to give your policy update, I will turn it over to you.
Great. Thank you so much for having me here today and to give the policy update. I had originally thought that the inpatient prospective payment system rule would be out by the time of this presentation, but it isn't. But I have some other stuff to talk about briefly. The first is the interim CMS RHC location determinations. CMS released an interim process for RHC rural location determinations following the census's new criteria for defining urban areas. Until further notice, CMS is going to use the 2010 and 2020 census urban criteria when making rural location determinations. Potential applicants for RHC approval and current RHCs considering relocation may use this interim process. Second, talk about the calendar year 2024 Medicare Advantage or Part C and Part D payment policy updates. This recently came out, update for both programs. It increases Medicare Advantage payments by 3.3% for 2024. You probably heard some of the news about this rule. It prohibits insurers from advertising plans in misleading ways, and it details appointment wait time standards for behavioral health, and adds a health equity index to the Medicare Star Ratings program for 2027. The Part D updates for 2024 include expansion of the low income subsidy program, and also it includes limitations of a month's supply of covered insulin products to $35 per month. Folks are still processing these policy changes since this rule just came out. Medicare Advantage is still lower in enrollment, still lower in rural compared to urban, but it is growing faster in rural areas than urban areas. The recent RUPRI study found that between 2021 and 2022, it grew from 13.4% growth in rural areas and versus 7.9% growth in urban counties. Just a few other things I want to touch on. The state timelines for unwinding the Medicaid continuous enrollment. As of April 1st, the states will resume eligibility reviews for enrollees in Medicaid and CHIP. This is also known as the unwinding of the Medicaid continuous coverage requirement. Resource, the Georgetown University Center for Children and Families maintains a 50-state unwinding tracker that compiles information that can be found on state websites. And I'm going to send a number of these resource links, websites to Laura after this meeting. Next topic is the updated fact sheets on the COVID-19 waivers and flexibilities. CMS updated the fact sheets for specific providers, including RHCs and critical access hospitals that describe the Medicare and Medicaid waivers and flexibilities that have been terminated either or made permanent or will end with when the public health emergency ends on May 11th. Earlier, CMS released an additional fact sheet titled "What Do I Need to Know?" I'll include that link as well. And finally, I want to talk about the guidance on the REH, Rural Emergency Hospital enrollment. On January 26th, CMS released guidance for the REH enrollment and conversion process for eligible facilities, and includes a frequently asked questions and a new state operations manual appendix with the conditions of participation regulatory text. Before that, CMS issued instructions on how eligible hospitals can submit applications to convert to an REH, and guidance to the MACs, the Medicare Administrative Contractors, on how to process REH enrollment applications and how to update payment systems that process REH claims. And one last thing I wanted to mention is that related to rural emergency hospitals, the NASHP is hosting a webinar on this coming Monday, April 10th from 1 to 2. And in this webinar, you'll hear from CMS talk about the REH requirements, and you'll also hear from a couple of states who are implementing the new designation in Kansas and Michigan. And I can provide the registration link to Laura when I send it. So that's my update. Any questions?
Any questions for Craig? Feel free to unmute, or you can put those in the chat. Get back, and I'll quickly give the task updates, and then we'll turn it over to Laura for federal office updates. Just a reminder, the Flex Reverse site visit, I hope to see most of you there, July 19th and 20th in Washington, D.C. Registration will be opening on April 17th, so you can be looking for that in your email this month. We also have the Developing Leadership and Workforce Learning Collaborative. We extended the application window, so if that's something that you're interested in, it will kick off in May. And you can follow that link for more information, or you can reach out to me and I can send you all of the details. But we would love to see more of you guys there. It's 5 sessions sort of over the early part of summer, and I think it will be really great. So would encourage you to look at that. We've got a couple updated resources. The HCAP Spender Directory is updated for the spring, and the Staff Sustainability Guide and Toolkit is updated. So check those out if you're interested. Of course, everyone knows that the NCC submission is due on May 5th. I'm sure no one's forgotten about that. But I did want to remind you that if you would like TASC to review a component of your application, just email us that component, whatever you would like it to be, by April 20th. Give us about 5 business days to review that, and we will get it back to you with our comments. And we would love to do that for you if that's something that would be helpful to you or that you're interested in. So I didn't want you all to forget about that. And I'm going to turn it to Laura.
Thank you so much, Kayla. My update is going to be very quick today. I did want to highlight one thing that came out in our FORHP announcements, not this morning, but they came out last week. We actually have a new funding opportunity. It's called the Delta Health Systems Implementation Program. This is open specifically for hospitals that are in the Mississippi Delta region and implementing projects that will improve their financial sustainability and allow for increased access to care. We have approximately $2 million across 5 awards, and it's for hospitals to implement projects focused on financial and operational improvement, quality improvement, telehealth, and workforce development. I am going to drop a couple of, I'll drop that blurb in the chat box along with a link to a live webinar specifically about this NOFO that's next week. And if you have any questions, you can reach out to Suzanne Snyder. I know some of you may know her already from the SOAR side, but I can drop her email as well. Again, just for hospitals in the Mississippi Delta, but I'll send that information in the chat box in a second. And beyond that, I will just give a reminder that your NCCs are due on May 5th. So please, 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 if you have questions, concerns, anything that you want us to look at as project officers, if you have updates that you want to make for next year and ask if things are allowable or not, please reach out to us. We are here to help with whatever you need, and so is TASC. We are all here, Arkita, FMT, everyone will help out if we need. So just don't hesitate to ask any questions. And that's it on the FORHP side. So I'll throw it back to you, Kayla.
Thank you so much, Laura. Any questions for Laura? Feel free to unmute or put them in the chat. I'm going to turn it over now to Megan for the Flex Monitoring Team update.
Great, thank you so much, Kayla. So we have a few updates of new Flex Monitoring Team products that were released in the past couple of months. We had one policy brief on care coordination and community partnerships for cancer care in critical access hospitals, another on workforce during COVID-19, and third on patient transfers to and from CAUSE during COVID-19. And I'll drop those links in the chat in just a minute. Also, our quality data on Compass for 2021 has been updated. And the most recent MBQIP quarterly reports, which include the Q4 2022 EDTC reports, the Q3 inpatient, patient safety and outpatient reports, and the Q2 2022 HCAHPS reports. All of the reports were released either earlier this week or late last week. So if you haven't seen those, please be sure to check your NIH workspace to download those reports for your state and your hospitals. And also in the next week or so, we should be releasing the annual financial state medians reports on our website. So look out for an email on that. And finally, we're continuing work on several of our other projects, including some looking at the financial impact of COVID-19 in CAUSE, advanced electronic health record use in CAUSE, and CAUSE emergency preparedness planning. So those are all the updates. As always, feel free to reach out to our team regarding any of our products, the Compass website, or MBQIP reports, and we are always happy to help.
Thank you, Megan. Any questions for Megan? Okay, I'm going to turn it over to Carla for our last update.
All right, thanks, Kayla. So we have lots of things happening, but I don't have a lot of final documents to share with you yet. Just one, actually, we have the updated data submissions deadline chart. So I will put the link to that. That's the grid that has all the data deadlines that has been updated, so that I will drop in the chat after my updates. I'll also put in the upcoming MBQIP virtual knowledge group dates in the chat. We did shift the date of the June MBQIP virtual knowledge group to avoid, I think we were trying to avoid the Western Region Conference, and by doing so, we hit something else. It is going to be June 8th, not June 15th. I think every week in June has a conference somewhere. So we apologize to those who will have a conflict for that, but I will get those dates and the registration links in the chat shortly. I want to say thank you to all of you who helped capture and gather information from your critical access hospitals as part of the MBQIP measures under consideration feedback process. There were about 100 comments that were submitted, some directly from hospitals, some from flex programs who captured and gathered information together. So we have been filtering through that and just presented a kind of a compilation of that data to FORHP for them to be considering. We have been working closely with the TASC team and the team at FMT. We hosted a joint in-person summit in early March to identify core elements of quality in critical access hospitals. So looking really at those infrastructure pieces, working through the report that will come out of that, and we're looking forward to you all having that available soon. It was really a pleasure to have both a wide mix of flex programs and critical access hospitals and folks who work on quality in critical access hospitals in the room together for a couple of days. So that was really a pleasure, and we think you'll be excited to see the outcome of that. Those elements are also being built into the pilot critical access hospital quality assessment that is going to be piloted in conjunction with the flex monitoring team later this summer. So lots of pieces and parts moving, but not a whole lot of products for me to be able to share with you yet. One other thing I want to highlight that is coming is that we will be doing, we'll have a quality improvement basics. I know some of you already use, Stratus Health has that online curriculum available called Quality Improvement Basics. Many of you use that. We're doing a refresh of that course that will be available later in April. Similar content, we just really have refreshed the look, broken up the modules in part. When we originally put that together a few years back, it felt kind of novel to have, 30-minute sessions. Now that feels too long. So we'll be releasing that later this month. And because the topic today is NEMSIS, I also wanted to highlight that as part of that release, we'll have an accompanying EMS QI basics infrastructure on the site for EMS folks to use as well. So those things will all be coming. I will put a couple links in the chat, and otherwise that's it for my updates. Thanks, Kayla.
Thank you so much. Any questions? Okay, perfect. I'm going to stop sharing my screen. I believe both of our presenters are here, so I will let them pull up their slides, and while they do that, I will pull up introductions. Okay. Thank you so much, Jeremy. I will quickly introduce you and Dr. Mann, and then I will kick it over to you. So Jeremy Kinsman is an emergency medical services specialist with the National Highway Traffic Safety Administration's Office of EMS. Jeremy has more than 20 years experience working as an EMS clinician in both pre-hospital and emergency department settings. As an EMS specialist, Jeremy manages the Office of EMS's research and performance measure initiatives and supports the administration of the National EMS Information System, or NEMSIS. And Dr. Mann is a professor in the Department of Pediatrics at the University of Utah School of Medicine. Dr. Mann has authored and co-authored peer-reviewed research articles dealing with traumatic injuries to children, trauma system evaluation, cardiac and trauma resuscitation, and the role of EMS in healthcare. Dr. Mann currently serves as the principal investigator for the NEMSIS Technical Assistance Center. And I want to thank you both for being here today. I think this is a great topic and not something that Flex coordinators normally hear a lot about. So thank you both so much. And Jeremy, I will kick it over to you.
Yeah, well, thanks very much, Kayla, for the opportunity to present on the NEMSIS program today. I think we're hoping that you'll find the information valuable as you think about how to kind of measure and enhance your Flex programs, specifically as they relate to the EMS. And thanks for the great background. I first came to the NHTSA Office of EMS in 2015 as a public health fellow. And at that time, I primarily focused on using kind of NEMSIS data to conduct traffic safety and public health research. I then spent a few years at the Yale School of Medicine, where I worked primarily on some clinical quality measure projects, and just returned to the NHTSA Office of EMS as a staff member this past November. So I work really closely with Eric Cheney, who some of you may know. He's another staff member in the NHTSA Office of EMS. I think he may try to join us today. Eric, for our office, he manages the NEMSIS program. And we both work really closely with Dr. Mann at the University of Utah, who's led the NEMSIS Technical Assistance Center, I think since 2005, which is just incredible. So I'll just kind of stop there. Clay, if you want to say a few words, and then I can run through the first set of slides.
Very happy to share just a couple of thoughts. Yeah, it's a pleasure to be here. I think the value of us being able to meet with you, right, is the importance of pre-hospital care in rural areas. I know Jeremy and Eric continue to talk about the needs for us to be able to provide the type of enhancements and kind of assessments that are really important to rural EMS. I think the presentation today will help you understand the collection of data, the clinical data associated with EMS care across the country, and how you might be able to implement that in really meaningful ways with real-time data to kind of assess any projects you may be thinking about implementing within your Flex programs in these rural areas. And Jeremy, turn it over to you.
So these are the items that I think Clay did an outstanding job there of just kind of going over what we hope to just cover today, but just a few bulleted items here about what we'd like to discuss. Just So you all are aware. I'll just provide a brief overview of the NHTSA Office of EMS, where I work and Eric Cheney works, just highlighting some of our programs and projects. And then I'll hand it over to Dr. Mann for a more detailed presentation on the NEMSIS program. We'll spend a few slides on the National EMS Quality Alliance, or NEMSQA. NEMSQA develops and validates EMS performance measures that use NEMSIS data, which we think will be valuable information for you all as you think about, supporting rural AMS in your states. And then we can just open up the floor for any questions or other items that you'd like to discuss today. So just a little bit about the NHTSA Office of EMS. Our perspective is really that emergency medical services exists in this really unique position, kind of at the intersection of public health, public safety, emergency management, and healthcare. And so many of the programs and projects that we administer out of the Office of EMS, they're centered at that intersection. And of course, that includes NEMSIS. So I think probably as many of you are aware, our EMTs and paramedics, they're in this really unique position, especially in rural parts of the US, where we've historically had a lack of available healthcare services, and are now seeing a lot of hospital closures. And so EMTs and paramedics, I think they do respond to emergencies that require that immediate life-saving care, which in itself is unique, but they also respond to a lot of calls where they're witnessing firsthand kind of how people are struggling with poverty or homelessness, substance use disorder, food insecurity. We also often encounter people kind of challenged by medication management or healthcare access. And so I think with that said, what's really valuable at NEMSIS is that it provides EMTs and paramedics with a tool to kind of collect and capture that information, describing the challenges our rural communities are facing. Again, kind of in the terms of that intersection of healthcare, public health, public safety, and emergency management. A little bit just on the NHTSA Office of EMS mission. So our office is located at the National Highway Traffic Safety Administration within the U.S. Department of Transportation. And so we do have this focus on reducing death and disability on our roadways, but our office, I think, really primarily kind of works on assessing, planning, developing, and promoting EMS systems that should be healthy and be able to respond to and care for patients suffering from any type of a medical emergency or trauma. And so we work closely with our federal partners on advancing this kind of national vision for EMS through projects and research that we fund. We administer programs and projects that are intended to measure kind of the health of the nation's EMS systems and deliver the data that EMS leaders need to help advance their systems at local, state, and national levels. And that, again, of course, includes NEMSIS that we're talking about today. So just a little bit more on some of the more specific things our office does. We've really worked kind of for 50 years now on improving EMS and 911 systems by working with our federal partners and national associations to kind of create resources that states and locals need for their EMS systems. And this includes the Federal Interagency Committee on EMS, or FICMS. And so through FICMS, we work with our colleagues across HHS. So of course that includes HRSA, but we also work with the Department of Defense, the Department of Homeland Security, and the FCC. And we also administer the National EMS Advisory Council, or NEMSAC. That consists of 25 members of the EMS community, and they represent various EMS sectors. So kind of specific to rural EMS, there's NEMSAC members who represent volunteer EMS, and then separately we have a member who represents tribal EMS, and then a separate member who represents public health. And so we work really closely with them on making sure that we're up to date on issues that folks working in the rural EMS space are experiencing. And then some other things that our office kind of works on. We develop and regularly revise an EMS scope of practice model document, and that's used by kind of states to help inform their state rules, regulations, and codes kind of concerning what EMTs and paramedics are authorized to do in the field. And we also work with our national partners to produce education standards. Those are used by EMS education programs and EMS educators, really to kind of ensure that our EMTs and paramedics are acquiring knowledge and skills that are safe and effective, and that are kind of based on the most recent scientific evidence and data. And then we also administer projects that develop EMS evidence-based guidelines, so that our EMTs and paramedics are kind of, again, providing the most effective interventions according to the scientific literature. So some of the EBGs that we've developed, over the past 5 or 10 years, we've developed some on the administration of naloxone, on field trauma triage, pre-hospital airway management. We've done some on like EMS clinician fatigue risk management, seizure management for pediatric patients. And I think the other thing that I want to mention there about that is a lot of the scientific literature that's helping to inform those evidence-based guidelines is coming from research that has used NEMSIS data. So there's this kind of loop going on where we've established the NEMSIS program. EMTs and paramedics are using the NEMSIS standard to do their documentation, and then we're in turn using that to produce studies and produce literature that then kind of goes back and funds, again, the scope of practice model or education standards and evidence-based guidelines. So really NEMSIS is kind of critical and integral to everything that we do in our office. All of the programs and projects that we administer. In the interest of time, I won't go into any detail here, but I just wanted to make sure folks were aware that the NHTSA Office of EMS, we also house the National 911 program, and that's led by Brian Tegmeyer and Kate Elkins in our office. So, as you're working with folks in the EMS space and the rural EMS space, if you have questions or thoughts about 911, you can always reach out to folks in our office. And I think with that, I'll hand it over to you, Clay, and then I can just advance the slides for you.
All right, fantastic. Yeah, it's a pleasure to talk to you about the NEMSIS project. And as I mentioned, I think my purpose here is to help you understand the data collection process, how we actually collect clinical information and EMS systems information from across the country, really with the idea that you could potentially use this data set to look at EMS care or some type of intervention in the rural areas of the country where you're working, right? So, kind of historical experience, tells us that really some of the hardest attributes of carrying out intervention is being able to assess whether the intervention was successful, right? How do I have access to historical data before I did the intervention to compare to what I'm seeing now with the intervention? All those types of questions that are associated with, getting funding to improve care or to improve some attribute of the healthcare system in rural areas, and how do I determine whether I had any kind of an effect? Well, the value of NEMSIS data is that it really does provide you with a mechanism whereby you could look at improvements in pre-hospital care. So I'm going to highlight some of the attributes of the data collection in this process with that in mind, and I'll try to point out the value of different attributes of the NEMSIS project. In essence, the purpose of the NEMSIS project is to kind of standardize the collection of clinical information across the entire country by providing a documentation standard. So that makes sense, right? To make sure everybody is collecting the same data with the same definitions for the elements. But then the value of NEMSIS is that we ensure that every single patient care report that's completed in a Toughbook or a laptop by our EMS professionals, that it's completely standardized. Each of those software products are tested for compliance to ensure they're exactly the same. And really that allows for this interoperability, so data can move very quickly and can be aggregated in a national database that you would have access to. Next slide. So let's talk about that a little bit, right? So the NEMSIS project, it was kind of built as this wide palette, right? It included all elements that an EMS agency may want to collect in their own agencies. But then there's a subset of data that, depending on the state you work in, the state requires that you collect that additional data And then we asked the states, and they kind of adhere to that, to collect 155 additional elements that are collected at the national registry as well. So there's really this complete collection of data from across the country at the national level. And each of the state repositories also have even more elements than 155. We just take a subset into the national database. So all of the state registries include very rich data as well. And we'll talk about that in a moment. Next slide. So yeah, so the way this works, right, we provide this kind of beating heart that all of the software products can utilize. It really includes all the definitions I talked about, all the pieces to the data collection, plus the interoperability standards, so data can flow. So if you see this slide here, we have 3 different agencies in the square block, right? Each of those agencies have software. They're at the site of a patient in the living room, completing a record. We provide our structure, our XML structure, to medical device information, to 911 call centers, so that data can flow directly into the patient care report. They complete the record. They press, I've completed this patient care report. And then that data is sent to state repositories like I talked about, and then a subset of data comes to the national database. Well, if we conduct kind of a tabletop experiment where I have a paramedic in a living room in Fargo, North Dakota, and I'm on the cell phone with him or her, and I say, okay, press that button that you're done with the record. The time that it takes for that record to leave that living room in Fargo, go to the North Dakota state registry, and to the national registry is 7 minutes. So the data is incredibly timely, right? Both at the state level and at the national level. Next slide. And then, of course, the other value of NEMSIS is that we collect data from all EMS activations in all 50 states, the District of Columbia, and 3 territories. And so you can see on the current version of NEMSIS, version 3.4, the green map on your left, we collect all the data. We're moving to a new standard, a version 3.5 standard, and states are now slowly moving over to that new standard. But the 2 standards are backwards compatible, and so you wouldn't see any disruption in the data collection within your states. Next slide. So as I mentioned, we are very close now to a complete census. If you look at this chart with calendar years on the x-axis and the number of states that have submitted to NEMSIS over those years with the blue bars, and then the number of events we collect with the orange line. In 2022, we just closed that data set and we collected 53 million EMS activations from across the country, District of Columbia, and the 3 territories. It's as close to a complete census as you'll ever get, right? So regardless of where you're working in the country, whatever rural areas you're interested in looking at, states are probably collecting that EMS data in a very timely fashion, and it's available in the national registry as well. Next slide. So let's kind of put this together to kind of I gave you a feel for how quickly the data comes in and potentially how it can be used. So I just wanted to show you just a quick snapshot of a Tableau screen that I see on a regular basis. This was back in February. Really, it kind of talks about the number of records that we're receiving per day. That's in the green bars on top. And then you can see in the second set of green and orange bars, that's the number of individual patient care events we've received. Those in orange are just indicating that there was a warning that was indicated by our logic checks that are required to be looked at. And they're warnings instead of errors because there are clearly situations where they apply, right? So that doesn't mean it's dirty data. It just means that it's been collected to make sure it's correct. But what I want to point out to you is in the red square, you can imagine in the pre-hospital setting that, yeah, you can close that record in 7 minutes, but what if I don't know the name of the patient or they're unconscious and there's information that I can't collect? So we don't receive records in 7 minutes, but this gives you an idea of how timely the data would be in your state. So we receive about 25% of the records that occur on any given day in about 13 hours. We have about 50% of those records that occur on any given day in about 61 hours. And then you can see really 75 to 80% of all the data is available in really a week to 2 weeks. Really, within 2 weeks, we have really close to a complete census across the country. So the data is incredibly timely. Next slide. So there are lots of different ways to utilize this data, right? Lots of different ideas or things that you could look at in your pre-hospital setting, where you could use this data to actually monitor or surveil some change that you have implemented with an intervention. Next slide. And we do that through a number of dashboards that we can make available at the state level, and then or at the national level. But there's also lots of data that's available at the state level. So let's walk through kind of an example of a surveillance type process where you can see how useful the data can be. Next slide. All right, so let's talk about COVID. NEMSIS EMS data was incredibly valuable across the country to kind of look at, of course, early on, EMS providers arriving at a scene don't know whether a patient had COVID or not, but we could look at what we call ILI or influenza-like illness symptoms across the country. We could look at how quickly, when we're using our personal protective equipment, right, that was so important during COVID, how quickly are we offloading and turning around our ambulances, getting them properly sanitized and ready for the next call? And how are we tracking like actual potential COVID cases across the country and ensuring that all of our providers had adequate PPE, personal protective equipment? Next slide. Here's an example from a published article in JAMA where some folks looked at this late in 2020, right? So they were looking at potentially overdose deaths. And so let's concentrate on the chart here on your right. So if we look at, we had the total overdose deaths reported in the CDC, and this is their provisional data. Their data takes about 9 months to a year for it to be considered a non-provisional, right? That it's actually solid data. And then you can look on the y-axis and you can see the number of EMS overdose cardiac arrests per 100,000 people. Now, the y-axis and the x-axis are clearly different because you wouldn't expect a one-to-one match for deaths for those who are suffering cardiac arrest from overdoses, right? There's going to be some that die of other means and other things like that, so they wouldn't be exactly the same. But what's interesting here, of course, is during the pandemic, the number of overdoses increased dramatically. So you can see all of the dots for the correlation between the two measures. For the gray 2018 and the blue 2019 are all bundled lower because we had this exponential growth during the first 7 months of the pandemic. But you can see how closely EMS data for cardiac overdoses related to or cardiac arrest related to overdose, how well that correlated with the actual provisional overdose that were reported to the CDC. So almost perfect correlation between the two. The interesting thing is, of course, the EMS data was available within 2 weeks, and the overdose data really is not available in anything but a provisional form for probably like 9 months. So clearly, EMS data can be used to really look at what's real time happening within your communities. Next slide. So there are lots of ways to look at the NEMSIS data. You saw a slide a couple of moments ago that showed some Tableau dashboards, and there's a great Tableau dashboard that if we had time, we could highlight related to the NEMSQA measures, something that Jeremy's going to talk about. But we also have a cube where you're able to access 103 million EMS activations over 3 years and look at all kinds of questions and be able to drill down with state permission, be able to drill down to individual agencies, individual counties, areas where you might implement an intervention. And so you could look at historical data in that area before the intervention and afterwards, or you could compare your intervention area to another area of your state. Those types of analysis are completely possible with NEMSIS data and in a timely fashion. Next slide. So that gives you a brief kind of overview about how the NEMSIS data is standardized across regions, right? So if you have an intervention related to your FLEX program in one area and not another, the data collection is going to be the same, right? So if you wanted to reduce response time within your communities with a FLEX program, you would be ensured that response time is captured the same across your entire catchment area. Or you could look historically versus what happens with your intervention. So lots of opportunities to utilize that data and to be able to work with your states or work with us at the national level to actually provide a mechanism whereby you could look at changes in performance, clinical performance, changes in system response, or just changes in the prevalence of something or incidence of something within a region. Next slide. I think that's an overview of the NEMSIS project. I'll turn it back over to you, Jeremy.
Okay, great. Thanks, Clay. Yeah, so for the next 2 or 3 slides, I'm just going to present some information on the National EMS Quality Alliance or NEMSQA. They were kind enough to provide us with some slides for us to present today. So as I kind of mentioned at the top of the presentation, we just wanted to highlight some of NEMSQA's work since they develop and kind of validate EMS performance measures that use NEMSIS data, which we think could be valuable for you all. So just a little history and background on NEMSQA. I think they did receive some like startup resources and support from our office and maybe some other federal partners, but they now are just a self-sustained and independent nonprofit organization. They really work to kind of bring together various EMS stakeholders to propose, develop, and validate EMS measures that can be used by local EMS agencies, by state offices of EMS, and folks at the national level, like the NEMSIS Technical Assistance Center, to kind of gauge performance of EMS systems and provide some measurable ways so that we can understand like how to pursue improvement, that would include both patient outcomes and provider safety. These are some of the member organizations and kind of federal and corporate partners that are involved in NEMSQA. So you can see there's several like professional organizations like the American College of Emergency Physicians and the National Association of EMS Physicians. There's our state partners at the National Association of EMS Officials. And then of course us, NHTSA and NEMSIS. And then we've got some folks at HRSA who also are involved with NEMSQA. So just a little bit on that. And then this is just a kind of a quick snapshot here of the current NEMSQA measures, which include, clinical treatment, some things on documentation items. I'm guessing this pediatrics 03B documentation of estimated weight in kilograms. This may have been one that they worked with folks at the HRSA EMSC program on. There's items on patient assessment and patient transport to an appropriate facility. So again, kind of as Dr. Mann mentioned, I think the important thing related to our discussion today for all these NEMSIS measures is that they use NEMSIS data elements. So all of our local EMS agencies, again, the states, the NEMSIS TAC at the national level, we can all calculate at those 3 different levels these measures for kind of benchmarking and performance improvement. And so I think the next thing I have here is just we'll put together a set like a PDF with the slides so that if folks are interested in learning more about NEMSQA, there's some links here to their resources and some contacts. And then there's also just kind of this last page here about ways to kind of connect with the NEMSIS TAC. So I'll stop there, and I know I'm sure we'd be happy to answer any questions that you all have, or just kind of continue the discussion as you all see fit.
Thank you, Dr. Mann and Jeremy. And we do have plenty time if you wanted to talk more about the Tableau dashboard. And we also have a couple questions in the chat. So I can read those. So John says, what are your thoughts on the tension between the emergency meds doc contingent that pushes for best practices that lean towards specialized training, etc., and the pushback from smaller services that don't see that kind of need and feel it creates obstacles to recruitment and retention?
Oh, excellent question, Jeremy.
Yeah.
I'm gonna let you answer that one.
Yeah, I'm just kind of reading back through it here to make sure that I'm understanding it correctly.
And perhaps I can explain it.
Yeah. Go ahead.
So in our state, we have a physician advisory council to the state EMS board. And what we see emerging from that is very specialized physicians, so emergency medicine, wanting to really go for the kind of the best of the best practices, and the very thorough training, which is absolutely true in the abstract. However, in sort of the pragmatic day-to-day approach, what we see is pushback from the services who aren't paramedics, who don't have an emergency medicine certified medical director, et cetera. And so they're saying, most of our calls are handled with kind of BLS type of activities. And so let's not educate this industry out of the possible pool for limited return on investment. And so that's the tension that I see. On one hand, we all want the standards to be better for our patients. On the other hand, a lot of those pushing those higher standards are coming from urban settings, larger systems, highly educated, high-level provision. And so those of us caring about rural services, smaller services, often volunteer level services, are saying, oh, okay, all right, yeah, that's great. That's a best practice. What about the also great practice?
Yeah, and I think just a follow-up question: are those rural agencies? Is this like a state requirement where these rural agencies feel like they're going to lose their license to operate, or that their providers are going to lose their license because they're not attending those trainings, or they're not doing those trainings? And so is that their concern, or that,
Yes, there is. I mean, there's always the struggle for continuing for two levels, both entry into the field, recruitment, the level of training it takes to become an EMT basic or advanced or paramedic. So there's the concern about that, like, wow, as these requirements get higher and higher and medicine gets more complex, it's going to happen. But the speed at which it is growing, the complexity of it, the training requirements, is pushing back against those who want to get involved in the field. Also for continuing education, people who are very experienced, very proficient EMS providers are saying, wait, now we have to learn what? About, like, I don't see that kind of case, but once every 5 years, why do we, why is this a requirement? And so I think you have this tension between what we primarily see as urban systems, where they have really well-educated, paid career level services, and smaller services that, don't have those kind of needs, but are nonetheless being dragged along. And that tension is problematic in our state. And I don't think we're the only ones. We recently had part of the EMS board say they thought that medical directors must have a requirement to be a specialist in emergency medicine. And we're like, are you kidding? We can't get enough medical directors to begin with. We have too many milk carton medical directors. And now you want to make them like unicorns? Absolutely not. But they're not wrong. That would be better care. Like, that would be a more knowledgeable medical provider to advise a service, but it's just unrealistic in my mind. And so that's the tension. Like, how do you manage that? And I could see, and this could be unfair, but those of you working at the national level, you're going to be advise from even larger systems, even larger urban systems and highly academic institutions who are, again, talking about the best of the best practices. They're not wrong, but we have to think about the rest of the situations and the rest of the country where we're saying, look, we just want people to get there and be well trained. We don't need them to be magnificently trained.
Yeah. I mean, I think, thanks for answering that. I think you're right. I mean, the barrier to entry, so it's kind of two problems, right? The barrier to entry is getting more difficult, especially for folks that are in a rural area. So they're being required to complete more education and more training just to become an EMT or a paramedic. But then also once they become an EMT or paramedic, there's these additional continuing medical education requirements that they have that they may not be able to complete, especially if they're working in like a rural volunteer service where they have a separate full-time job. So I think, that's not, just to be completely candid, that's not an area within my office where I focus. As we kind of presented today, I work most closely with Dr. Mann on these like research issues. And I think probably one area where we could improve is maybe some better data collection. It wouldn't really be through NEMSIS, but probably something that we could do a better job with is working with NEMSIS on maybe data collection on education programs and personnel, and where we have kind of a lack of EMTs and paramedics, and how the requirements for entry and for continuing medical education have changed. And I think the other like big problem and challenge is also with just reimbursement and resources for especially our rural areas, right? If our rural areas and our rural EMS agencies were better resourced in terms of funding for those agencies and for those providers and training opportunities, right, then you could have like a really healthy workforce there that might not have these issues. And so I think that's something that we've struggled across EMS for a long time. I do think there are some kind of hopeful things on the horizon. I imagine you all are familiar with the CMS ET3 program, the emergency triage. Yeah, so hopefully we'll see some evolutions in EMS where things that we traditionally weren't reimbursed for, we can start to see some resources, additional funding for those EMS agencies, so that they can kind of provide the time and the resources that those agencies and personnel need to do those more sophisticated trainings. But I'm not sure that I have the right answer, but those are just some initial thoughts from us. And of course, as you all are discussing those items, please reach out to us, because we can certainly connect you up with the folks that are kind of working in the education space within our office and across the national organizations.
Yeah. Well, and thank you for that. And given your answer, I would just say that, so state offices of rural health, the folks that are on this call, a big part of our job is to always attend those state meetings and raise the hand in the back of the room and say, that's great. What about rural? How does this work in a rural setting? And so we would just ask that you sort of, as you're on these advisory councils, as you're considering measures, as you're considering scenarios, that you just think about flipping over that rural lens, that rural perspective, and say, okay, what does this look like in a small, in a EMT basic kind of level service where they're scrounging, their medical director is only there occasionally? What does it look like in this setting? Because again, we all agree, magnificently trained and the highest standards would be awesome. And then we have sort of the reality of that. And so we want to make sure that we're not outpacing the reality of our providers, because we're in such desperate straits for care. I'm not saying anybody with a pulse should be an EMT, but I am saying we have to be somewhat realistic when we're setting standards, when we're setting metrics, when we're setting best practices.
Thank you for that, John. And similar to John's point, Penny had a question. So she said, state level data was mentioned, but are there geographic fields in the data that would allow us to look at rural areas in our state separately from urban areas?
Yeah. How about if I take that one, Jeremy? It's much easier to answer than John's question. So so thank you, Penny. Hey, I'm going may I share my screen just real quick? I'm going to just show you some of the products that are available within NEMSIS. So Jeremy, maybe you need to.
Yeah, sorry, I'm just
Yeah,
Top share, there we go. Okay, it's been a while since I've used Zoom. I'm so used to Teams.
Yeah, yeah, I know what you mean. Okay, fantastic. Yeah, I'm just at the NEMSIS website. It was just nemsis.org. You can see it here. Yeah, NEMSIS at the national level collects data down to the zip code level. We don't traditionally release the data at that level, but within states, they collect very specific geolocators. So a Latin long of a call if it's on a country road, and or addresses. But here's just an example of one of the things that are available just by clicking on the opening page of the NEMSIS website, where you can look at opioid overdose by county, right? So this would be an incredible way where you could look at the rural counties within your state and determine where is there the biggest potential burden of opioid overdoses. These are events where EMS was called and they respond and they give naloxone, perhaps, if that's appropriate. All those are recorded here. And you can go down to the county level and really kind of see where the need is greatest. I'm going to go back to the NEMSIS website and show you where you can look at those NEMSQA measures that Jeremy talked about. So if I go to view reports and go to public reports, let's use the NEMSIS version 3 data. So the version 2 or older dashboards. There's the opioid overdose tracker we just talked about. Let's look at clinical performance of our EMS providers. So here's where each of those NEMSQA measures, where you can determine exactly how they're calculated and what they're looking at. Here's where you can assess how well an agency is doing, right? So I'm going to show you the national version that doesn't allow you to drill down to individual EMS agencies. You'd need to go to your state. They have a state version of this that goes right down to individual agencies. But let's just choose one. So one of those measures that Jeremy talked about was E in trauma 01, right? So if a patient is injured, did you assess them for pain? So incredibly important clinical measure. Well, so if I look at this dashboard, I've got 8.7 million EMS activations for injuries that we're looking at in 53 states and territories, 11,000 EMS agencies. Nationally, that value is 69%. So 69% of injured patients get a documented assessment of their pain. Well, let's say you wanted to find out within your state and your counties, even your agencies, what their level is. You can do that on the state level dashboard, but you can also tell your EMS agencies, hey, the national average across the entire country is 69%. How do you compare to that? And you can even drill down a little bit more. So say, okay, I run a flex program in the West states, and I deal with rural parts of the state, and my EMS agencies are for the most part volunteer, and they're fire-based, and they see less than 1,000 calls per day. You can drill this down, have your agencies drill down to this, and as mentioned by John, let's say they're BLS equipped. Well, so for that characterization of EMS agencies, the value is 65%. Right, so a historical quick look at where they are on any of these measures, you can determine what's their clinical performance now, and you could benchmark them in the future using the same metric, right? So lots of opportunities to utilize NEMSIS data to answer questions or help you with the assessment of an intervention in the pre-hospital setting. So Penny, I hope that answered your question, plus a couple others.
Great, Dr. Mann, thank you. I think it helps a lot to see it in action like that. Do we have any other questions? Feel free to come off mute or to put those in the chat, but I wanted to give everyone a chance to ask any questions they have.
Yeah, I have a question more about data than the specifics. What are some of in applying this data in our rural communities, our hospitals, things of that nature, what are some of the limitations to these data points that I might expect to encounter?
Wow. Wow, that's a really good question. I'm going to, okay, one more thing I wanted to share with you. If you're interested in learning more about NEMSIS data within your state, if you click on either of these two maps, the current migration of states or those that are using version 3.4, you can click on any state. I can click on my home state and it will indicate that I need to contact Felicia, right? So you can find out who knows everything about NEMSIS data in your state just by clicking on this map. Clearly, there are limitations. I mean, probably the most important ones are EMS providers are primarily responsible for your health and not your data collection, right? So they do a great job of collecting the data, but they're going to care for you first and make sure that you're healthy. We have lots of business rules to ensure that they complete the record, but they're not professional coders, so that's probably important to measure or to remember. I guess the other one that is common question in NEMSIS is the NEMSIS registry at the state level and the national level is not patient-centric. It's not patient-specific. So in your rural areas, if you have a two-tier system where like a fire truck first comes and stabilizes you, and then an ambulance follows and takes you to a hospital, or if you go to a local hospital first, a critical access hospital, then you're transported to another hospital, there won't just be one record for you. There'll be a record for every EMS apparatus that is activated and comes and treat you. So here in Salt Lake City, if I called 911, I'd get fire folks come and stabilize me, and then I'd have Gold Cross come and transport me. There'd be two records in NEMSIS. So you can't count NEMSIS measure records to indicate the number of patients. Those are, Jeremy, can you think of any other?
Yeah, I mean, I guess the only other thing I'd mention is we've been challenged by this for a long time, and I think we're seeing some progress in this space, which is related to like linking EMS and some other data systems. And so Dr. Mann mentioned a lot about how we've worked really hard on interoperability. And so I think we continue to do a lot of work in that space, and we're getting close to where we'd be able to link EMS and emergency department or hospital data. One of those things that we didn't have time to talk about today, but is this universally unique identifier, which is in version 3.5 of the standard, that's going to allow us to link, to deterministically link NEMSIS and trauma data. So we'll finally be able to get some of our hands on that linked data so we can look at outcomes. So that's one limitation that we have right now. It's hard for us to look at hospital or emergency department outcomes. But stay tuned because it's coming.
That was very helpful. Thank you.
Yeah. Thank you both. Penny, I see your hand up.
Yes, and it'll take me longer to figure out how to put it. Oh, wait, no, I figured it. Oh, I was really hoping y'all were going to say NEMSIS is now available. You can just go in and download the data, but you still need the state's permission. And so, at least in our state, I also need the state's permission to access our run system here, our state version that feeds into NEMSIS. So if I'm going to have to get permission to get one, my gut tells me to go with Wards, which is the Wisconsin run data system, versus NEMSIS. But is there an argument the other way? Like, is there value of one over the other? Will the data match? And I don't expect it to, because I know enough about databases to know that the data never matches. But can you maybe speak to that one versus the other?
Yeah, Penny, it's a great question. I'll respond first. Jeremy, would love to hear from you. So the really cool thing about NEMSIS is that the data sets will match, right? So that's the cool thing, is that every state has every single record that we have at the national level, right? Because they're just sending a copy of the subset of the data to the national level. National level, you can't traditionally drill down to individual agencies. And so you're right, you'd have to access the state level data to look often at county specific information or zip code specific information or address. You're right. So really, if your interest is really being able to assess an intervention, for example, that you utilize flex dollars for, then yeah, you'd want to have a relationship with your state and talk to them about, hey, how can I use NEMSIS dashboards to look at state-specific data? Because all the states have very specific dashboards on the same website that drill down to the much more specificity. Can I contact you on a regular basis to look at the value in this dashboard, for example, or something like that? But you could work with your states, I think, to determine how best to access that data. But that's probably best. Jeremy, any thoughts?
Yes, I think you're right that, and Clay, you can correct me if I'm wrong, but like we don't have a process in place where you can just go to the NEMSIS website and just download like the National Public Use Research Data Set. But I think there is a place where you can go and just submit a request for the data. And I think like Clay, right, just a little bit information about the analysis or what you're looking for. So we do have that. And the NEMSIS, Clay's team at the NEMSIS TAC, they do it very quickly. And they will send you the information you need, either like on a USB drive through the mail securely, or I think you guys also do like SFTP or like secure box downloads. So there is a way to access that data. It takes a few steps rather than just like going to a website and clicking download. And then the other thing I'll mention, Clay, is, kind of correct me if I'm wrong here, but I think under version 3.5, right, we have data use agreements with states that will start to allow us to show data at the incident, state, and county. Yes. Which is new. I mean, you still wouldn't be able to identify an agency, like if you wanted, as part of your flex program, if you, like Clay mentioned, if you wanted to see how an agency within your state was doing, you'd still need to go to the state data for that. But if you wanted to do, if you wanted to drill down to the, to look at information that we have at the national level that's specific for your state or a county within your state, that's another thing that's coming, sometime in the next year or so.
Yeah, thanks, Penny. Feel free to reach out to me. I'd be happy to help you with any kind of request, either at the national level or if we can help serve as a liaison to the state. Happy to do that as well.
Thanks.
I want to keep the conversation going and have opportunities for any more questions, but before I forget, I was going to ask Patricia to launch those post-polling questions so you guys can complete those before you leave today. I'll give everybody a second to do those. And I had a question for you all, and I apologize if you answered this at some point, but is there any cost associated with either NEMSIS or NEMSQA or anything that we've talked about today?
Yeah, great question. So access to the NEMSIS data is completely free, whether you're downloading the entire data set or utilizing the cube or any of the dashboards. That's all free. And I don't know about NEMSQA. I don't really understand that process very well, but I don't think there's a charge for looking at what measures are associated with clinical.
No, I don't think so. I mean, I think, they can go, I think states and agencies can go to the NEMSIS website, like Clay had did a great job of showing us, and kind of see how they compare, right, to national averages or to averages within their state. There's no charge to states or agencies to do that. And then I think a lot of the patient care report vendors that agencies and states use, so like Image Trend or ESO, they may calculate those NEMSQA measures. And I don't know how that works. I don't know if they charge them an additional fee to calculate those measures for them, or if they just include it as part of the software purchase.
Thank you for that. So sort of back to what Penny was asking about, how would you all say that state level data managers, are they pretty open to sharing that state data with a flex coordinator or somebody that would utilize the data in that way? Or is there any like tips or tricks or magic words that flex coordinators could say when they reach out to those folks that might encourage them to be a little more likely to share? Because I know sometimes that can be a little iffy, data sharing and all that from state to state. So just curious about that.
Yeah, that's a great question. And it does vary from state to state, but I would say that most of the states are very open to sharing their data. That wasn't the case years ago, but I think it is now. And one of the true values, right? One of the magic words, I guess you could use is say, for example, where we're showing those performance measures for NEMSIS, if you chose to try to improve something related to clinical care. The dashboard, once you get the visualization up that you're interested in, the Tableau dashboard allows you to snapshot that into a PDF, right? So you could go to your state data manager and say, hey, we're interested in making sure that everybody that is suffering an injury needs to have a pain assessment. EMS needs to know whether they need pain medication on scene, right? Then you could say we're gonna implement it in these agencies, and I want to kind of know what the state average is for it, right? Something like that. Well, then they could whenever you ask them to, they could actually go into their Tableau dashboard, choose the agency, download all those numbers for you, and then just hit PDF and send it to you, right? So they don't have to give you access, things like that. So if you have an idea, I would say contact Jeremy, contact me. We'll talk you through what processes are available that could answer that question for you using NEMSIS data. And then we work very closely with your data manager to help them understand what's the most efficient way to do that, protecting the confidentiality and state requirements for that data.
Thank you, Dr. Mann. That's such a generous offer, and I really appreciate that. And I think it makes it a lot less scary for coordinators to reach out to those people, because I know that can be intimidating. And John says, in Washington, our EMS Flex Grant team works directly with our WMSIS and RAD team. And John said, our colleagues in the state EMS office are much more open than the legal team at the Department of Health, which is no surprise. Well, thank you to both of our presenters. This has been great. I really appreciate you all coming on today and for putting up with the probably dozen emails that I've sent you leading up to this. So thank you so much for that. And thank you to everyone for being here today, for completing those polling questions. And I hope everyone has a great rest of your day. This is recorded. We'll send out the recording, so you'll see that soon. And as always, reach out to TASC with any questions you have. And with that, I will say goodbye and thank you all so much.
Thank you.